And with immaculate timing, if you're happy, Saj, we will now go live.
Thank you.
5, 4, 3. Good morning and welcome to the final session of the Health and Social Care Select Committee's inquiry into clearing the backlog caused by the pandemic. And we're pleased this morning to welcome the relatively new Secretary of State for Health and Social Care. Thank you very much for being with us this morning. Welcome to your first and the first of what we hope will be many appearances before our Select Committee. And we are genuinely pleased that you're joining us. And we'd like to start, as we often have in the last couple of years, by thanking you and your team and asking you to thank everyone in the NHS and care system for the incredible work they've been doing through the pandemic and indeed in dealing with the backlog. May I start with some questions on the budget and spending review settlement announced last week? We know that the health and care levy will generate around 10 billion a year for the NHS, which according to the Red Book is about a 3.8% real terms increase per annum. But obviously, if we haven't got additional doctors and nurses to do all the extra procedures that are going to need to be done, then we're not going to get the improvements that everyone wants. So we know that over the last year there are 4,000 more doctors and 10,000 more nurses. But on top of the extra doctors and nurses we already have, how many more do you think we're going to need to tackle the backlog?
Thank you very much. And thanks for the welcome. And before I answer that question, if I may just take a minute to say something up front, which is to say, obviously, my first appearance in front of your Select Committee. I do also, like you, look forward to many more. It's a pleasure to be in front of you all today. I think also that just reflecting on the past 18 months or so for everyone in the country, but especially anyone that works in health and social care, that it could not have really, I think it's hard to imagine, a more challenging time. I think it's clearly the most challenging in living memory. And those people, those in health and social care, have been at the front line. And one thing that was clear to me even before I took the job, but I think I can say even more so, having done this job for a few months now, met many of the people that have served and continue to serve on the front line of health and social care, that they've shown extraordinary skill, dedication and compassion, and what they've done has been absolutely vital, essential to our recovery from this awful pandemic. And as you know, my job is to do the best I can to both support health and social care, but ultimately to make sure health and social care are there for everyone in our country. And in doing that job, I think the work of this Select Committee is going to be really important to me and my team. The scrutiny that you provide as committee members, the scrutiny that you will continue to provide, including today, of course, I think it's an important part of our democracy, but also I think it ultimately leads to better outcomes. So I want to thank you all of that, in particular you, Mr. Chairman, for the work that you're leading through this committee, and I look forward to working with you all in delivering on that. In turning to the settlement and your question specifically around workforce, let me perhaps if I just start with this. I was just getting acquainted with some of the more recent up-to-date numbers on workforce and where we are. As you know, NHS in particular, one of the largest employers in the world. The latest numbers that I have, that as of August 2021, we're at 1.2 million full-time equivalent people working in the NHS. That's 1.3 million in terms of total headcount, and that does include already record numbers of doctors and nurses. Just in the last year, in trying to help, especially with the pandemic, we've seen an increase of over 20,000 in qualified clinical staff, which includes some 5,500 doctors throughout the NHS and over 10,000 nurses. As the committee will be aware, in terms of workforce and workforce planning, there's a number of commitments that the government has, which actually some of them were there before the pandemic. So there's a commitment of 50,000 more nurses by the end of Parliament, and so far we're on track for that with 10,000 more nurses. And a commitment also for 50 million more primary care appointments, which will need more doctors and other primary care staff. In terms of the settlement itself. As the committee may already be aware, but just to make sure of the sort of the headline numbers of the recent the SR outcome in terms of the workforce, the major impact will come from the sort of resource spending, the so-called RDEL funding that we will receive, and for the NHS that will be £15.7 billion of the. If you take the levy, the 1.25% levy on national insurance, over 3 years that will raise 36 billion, 12 billion a year, and over that 3-year period, and in terms of extra spending. So this is an addition on top of what was already planned for the NHS, so through the long-term plan and other ways that funding is untouched in terms of increases, and this is on top of that, this extra £15.7 billion of spending. The NHS will now be working to break that down in terms of what will be needed in terms of workforce, both dealing with electives and primary care and other levels of care that it plans. And it will set out, by the end of November, it will set out an elective recovery plan which will detail how it plans to meet its workforce requirements.
Thank you. That's very helpful, but we heard in evidence this committee the Health Foundation saying that in order to deal with the elective backlog, which the NHS says it's going to need to increase its capacity to 30% above pre-pandemic levels, the Health Foundation say that's going to need 4,000 more doctors and 18,000 more nurses. But in order to ask the Chancellor for those extra sums of money, you must have done calculations as to how many additional doctors and nurses you're going to need, because it's impossible to know the sums of money that you're going to need without knowing the extra capacity needed. So we just wondered, what is your calculation as to the number of extra doctors and nurses that you believe the system is going to need in order to deal with that backlog?
I couldn't give you an exact number right now in terms of what we're going to need, because up until very recently, the SR, as you know, was only last week. The first step was in trying to reach an agreement internally in government what the funding would be. Of course, we would have to have made assumptions around workforce need, capital need, and other needs. But once we've got the sort of final settlement, we wanted to make sure then that we just looked at this again publicly, properly in detail, then published our plans, and we will set out what those are in terms of
just to be clear,
numbers.
Because I think the concern that a lot of people have is that there is absolutely no detail in terms of the number of extra doctors and nurses that you think are going to be necessary. So you do have those assumptions, and you will be publishing before the end of November the number of extra doctors and nurses that you think are going to be necessary to tackle the backlog.
Well, what I will say is this, is that we will be publishing a elective delivery plan for around electives specifically. Now, of course, what we're doing, the work that we do, the department does, the NHS does, is broader than that. But specifically on the delivery plan, we will go into some detail about the workforce.
I'm so sorry to interrupt, but it's a very specific. I understand there's going to be a delivery plan, and you're going to be planning how many more operations are going to be done every year. And I understand as well, you can't tell us if you're going to deal with the backlog, because we don't know by how much the waiting list is going to swell in the months ahead. But we're looking at something very much more specific, which is a workforce plan. How many more doctors, how many more nurses? Let me give you some numbers. You'll be very familiar with these numbers, but so the Royal Colleges say that we're going to need 500 more obstetricians, 1,400 more anaesthetists, 1,900 more radiologists, 2,000 more midwives, 2,000 to 2,500 more A&E consultants, 2,500 more GPs, and 39,000 nurses. And in fact, there are 93,000 vacancies across the NHS in total. So there are very specific numbers in each specialty that the Royal Colleges are talking about, the Health Foundation are talking about. You must have those numbers. Do you have those numbers privately? We know you haven't published them yet, but do you have your own internal estimates of what the short?
Yes, of course. We have internal estimates. And now that we know what for the department and therefore for the NHS, what our final financial settlement is, we will be working on fine-tuning that plan. But
so
you will also know, Mr. Chair, you may well be aware that as well as sort of identifying immediate need, and colleagues will know that there was a shortage of clinicians, a shortage within the NHS even before the pandemic had begun, and you've just rightly referred to approximately around 93,000 vacancies at the moment, which includes, for example, almost 10,000 vacancies for doctors in the NHS. So a lot of this challenge existed even before the pandemic. It has become more acute because of the needs, but we do need, I think, we need better long-term planning of workforce needs.
Sorry to interrupt.
Yeah.
I will come on to the long term, but I just want to deal with the short term first. So by the end of November, there's an immediate short term need, and there are immediate short term things you could do.
Yeah.
For example, increasing retention, bringing back retired clinicians, changes to immigration procedures to make it smoother and easier for people coming from countries where we trust their medical training. By the end of November, we will have a workforce plan that says these are the gaps, specialty by specialty, these are the extra people we're seeking to recruit, specialty by specialty, and these are the things we're going to do in the short term, because the money from the levy starts in April. So we've got to get cracking pretty quickly to fill those workforce gaps. That workforce plan is what we're going to see by the end of November.
Let me be a bit more clear. What I referred to by the end of November earlier is a delivery plan specifically around electives. And of course that has a workforce need that comes with it. So when it comes to electives, in our delivery plan, we will set out how we would hope to meet both short-term and long-term needs in terms of workforce. But of course there's a broader workforce need, beyond electives. So for example, in primary care, in community hospitals, and elsewhere, and also social care. They're also thinking about the long-term need there, and the sort of interaction between the sort of need between healthcare and social care in terms of workforce. That work in terms of what planning better for that is a separate piece of work. That is
When's
already
that going
ongoing.
to be complete?
That is work that's been commenced already by HEE. That I'd asked them to, I think it was in July, that I asked them to start a piece of work that is we call it a 15-year plan to set up a strategic framework for long-term workforce need. It's a big approach. So in terms of timing for that, you asked me when that. It's spring next year is roughly the timing we set for that. And the reason is because HEE are consulting broadly and widely. It's a big tent operation, you could call it. They're speaking to academics, some of the organisations that you already have mentioned, think tanks. They're looking at demographics changes, technology changes, the use of technology and how that impacts workforce, the educational environment, economic changes, even behavioural changes towards work that we've seen because of the pandemic in terms of what that might mean. They're trying to take all that into account and come back to me, hopefully by spring next year, and set out a framework for long-term planning of workforce needs.
So I'm really sorry to I do want to talk about that, but I just do need to just be clear, because there's a workforce crisis now. You'll be hearing this every day. Yep. There's a particular crisis at the moment in A&Es. So just to finish this, on the short term, because the money from the levy starts next April, will you be publishing by the end of the year, let's say, not necessarily November, by the end of the year, what the short-term plans are, what you think the gaps are in the NHS workforce for the short term, specialty by specialty, and what the short-term plans are to deal with those gaps? Will that be part of what we get? Because I think many people on the front line of the NHS are absolutely desperate at the moment, and they love the idea of a long-term plan, but they want to know that there are things that are going to be happening right away. So are you happy to make that commitment that at least by the end of the year there'll be a workforce plan that says what you're going to be doing for the next 12 to 18 months to deal with the short-term issues?
Yeah, I'm happy to say that by the end of the year we will set out, not just through one document, there will be a couple of different ones. So for example, in terms of winter planning, we are also working on a sort of strategic narrative between NHS and social care, which will also address some of the workforce concerns, and that will be published also before the end of the year.
That's great, thank you. I just want to move on now to the long-term things which you're talking about, which are very important.
Yep.
Now, as you know, it takes 7 years to train a doctor. So it's incredibly important, if we're thinking about the number of doctors that we will need in 7, 8, 9 years' time, to be training the right numbers now. If you look between now and the end of this decade, the health foundations say we're going to need 488,000 more staff in the NHS and 627,000 more in the care system. HEE have not published what they think the long-term need for doctors and nurses in the NHS is since 2017. So we are going to get that number, are we, by the spring? That's why I just wanted to check. That's the piece of work that's going to be done.
Well, so let me say a bit more about that piece of work. And by the way, the reason I've commissioned that work is because I think from what you've just said, Mr. Chairman, and also what you've said in the past in Parliament as well, and others, about the need for long-term planning in terms of workforce, both for the NHS and care systems. I think you're absolutely right on that point, and I do think we need a better approach to this. As you say, the last plan was done, pre-pandemic, and obviously a huge amount. We couldn't have seen more change as we have since that date. And we do need a better approach to this. And what I've asked HEE to do, independently, is to do this piece of work where I've sort of called it referred to it internally as Framework 15, a 15-year, so looking at a 15-year horizon, so a very long-term horizon, taking into account the changes that we some that we can more or less predict in terms of some of the demographic changes, the long-term trends in demographics, some that will be harder around technology changes, the educational environment, the economic environment, the future approach, behavioural changes to approach to work, taking all of that into account, consulting far and wide with organisations you've just mentioned, Royal Colleges, other important players in the health space, and academics and others, and then producing publicly for publication, not just for me, but of huge value to me, of course, a framework to make these decisions. Now, you just asked me, will they put a number on that and say, you need this, X of this type of clinician and Y of this, or this is your demand and the need of nurses or midwives? I couldn't tell you that at this point if that's exactly what they've come up with. I've given them a mandate here to set out the framework, and I want them to go as far as they feel that they need to. But what I do agree with very much is that the way this has been approached in the past it has to change. We do need a much more longer term approach to this, and this is think of it as a significant step in doing that. It might not satisfy everyone in terms of the step that we've taken, and I am constantly reviewing to see what more we can do in the context of the bill that's in front of Parliament now, the Health and Social Care Bill. There has perfectly rightly been debate around this from many, including yourself and other members of this committee, and I'm listening carefully to that, and I'm looking to see if there are more steps that we can take.
Well, I'm really grateful for your engagement. I'm sorry, I just need to sort of move on because there are so many things to talk. So 2 weeks ago, Amanda Pritchard came before the committee, and she told us that any reduction, either a real terms reduction or either a cash freeze or any kind of reduction in the Health Education England budget, would be a real concern in the spending review. So we raced to that part of the Red Book that would tell us what was happening to the HEE budget, and there was absolutely zilch about what's going to happen. Could you tell the committee today what is actually going to happen to the HEE budget in the spending review?
Not yet. We're still, now that we know exactly what the settlement is, we are still making some final decisions, working with HEE, working with NHS, of course, on this as well, and making those final allocations. So we're still working through those, and I couldn't say what those are right now because the process is not complete.
I absolutely understand these things take time, but can you understand the concern on the front line when there is a workforce crisis, there are shortages in every specialty, when there isn't a workforce plan for the next year, 18 months, the budget doesn't even say what's happening to HEE's budget, and there's so much uncertainty, and there feels like a lack of direction, a lack of specificity in terms of what's happening with workforce and what the government is doing. Do you understand why that is a concern to many people on the front line?
I think given the demands on health and social care for that matter, I think it's perfectly understandable the focus on long-term workforce planning and training budgets, for example, as well. But I think people will also understand that the SR settlement has just been made. It's been allocated for all departments, and there will be some decisions that are made once the final allocation is known. But if I can just also say this, in terms of long-term planning, I think people also recognise there's a huge amount of work and investment that's gone into workforce to try and meet that vacancy rate that you talked about, which is around 7%, I think, roughly, of the workforce. When it comes to HEE and students, for example, we have a record number of people studying at the moment in our medical schools. In fact, the entrance this year, I believe, for GP training was the highest cohort ever. We've got some 35,000 people training to be student doctors, some 4,000 training to be dentists, 60,000 junior doctors in postgraduate training. Many of these numbers are record highs, and this year I lifted again the cap on medical school numbers. And so there is a huge amount of investment still going in. But that said, where I very much agree, and I think this is a point that you, Mr. Chairman, have made again today and have made in the past, and I think it's right, is that we also need, as well as the short term and what we're doing now, we need better long-term planning as well. And I hope the work that HEE, this Framework 15, that they're working on will help to do that.
Okay, two final brief ones from me. Can you not see, though, there is a problem in the system at the moment of accountability? Because the government won't publish the numbers of doctors that we think we're going to need in 10, 15, 20 years' time, because it doesn't publish the Health Education England budget, because we don't know whether the number of doctors and nurses we're going to be training in the next few years is going to go up or not. We've absolutely no way of knowing whether or not we're training enough doctors and nurses for the future. And that means that it's very, very difficult for us to hold you to account as to whether you're doing your duty in terms of what the long-term needs of the NHS are.
I think that there's been an approach sort of thus far involving HEE, the NHS and others, through which government has set out its long-term plans for workforce. I would like to see a change in that approach, and I'm very comfortable with more accountability and more transparency, and I hope that what I've already set out, some of it today, but also with the bill in front of Parliament now, we've added a duty for there to be a regular, for me as Secretary of State, to make a regular report on the workforce system. I think almost at least every 5 years. I mean, this is all new. It's all part of being more transparent and clearer about that need. And I think there is more to be done, and I think we're moving certainly in that direction. And I hope that with what we will publish, especially by the end of this year, and also this report from HEE in the spring, will help to set out our plans more clearly.
Thank you. And then just finally, you can see why, and I do appreciate there has been engagement from you in public and private on these issues, but you can see why, with so much concern about burnout, shortages, unsafe care, 50 health organisations, including all the Royal Colleges, all the health think tanks, people like NHS providers, and the Select Committee have all come together, and they've asked for an amendment to the Health and Care Bill that would give Health Education England a statutory duty to publish 2 yearly independent estimates of the numbers of doctors and nurses that we're going to need over the next 5, 10, 15 and 20 years, specialty by specialty. Can you see why people feel so strongly we need that kind of amendment, and are you willing to engage with the possibility of having it?
I'm willing to engage, and because I'm, like you and members of this committee, I think getting workforce right is going to be absolutely crucial, and it makes absolute sense to listen to those who have looked into this in depth. And so, of course, I'm happy to engage. I would not absolutely say at this stage, without having not had that full engagement, and also without listening to voices on all sides of this debate, there's no final decision on what amendments the government might be willing to support or not. But of course, I'm happy to engage.
Thank you. Anna.
Thank you, Chair. Thank you so much for joining us today, Secretary of State. So, in May 2020, the Scottish Government released a COVID-19 framework for decision-making called Remobilise, Recover, Redesign. It suggested that there's a need for a relaxed access to the international labour market. So what role, if any, does overseas recruitment play in tackling the workforce issues we have in NHS?
Thank you. The overseas recruitment is an important part of it. So when we, just to put that in context, so when we're looking at our workforce need, I think the sort of 2 or 3 things that have to be taken into account is obviously domestic recruitment. I've talked a bit about that a moment ago, for example, with the record number in medical schools. There's overseas recruitment, which I'll come back to, and then there's also the retirement. The retirement rate, so how many people might be leaving the system. Some have come back during the pandemic, but can we sustain that? That's an important part of it as well. And then also, not to mention, can we using technology, for example, can we find ways to have clinicians spend more time working on elective procedures and things, and less time perhaps on paperwork and bureaucracy, and can that help to free up more time? Overseas recruitment is a very important part. And that's at every level of need, and from the number of nurses come from abroad, doctors. I just recently, for example, made a visit to the GMC's training centre or assessment centre, I think it's better called, in Manchester for training of new, potentially, for overseas recruits as GPs once they've passed the GMC's assessment procedures. That is, when we do recruit, we have an ethical recruiting policy. So we work with countries carefully, the governments in those countries, to see that the way, if we are going to recruit in those countries, is it something that they would support, and do we think that it's a broadly an ethical approach? But it is an important part of meeting the needs of our workforce overall.
Okay, so thinking about kind of lower paid jobs, and specifically thinking about those in social care settings, it's widely recognised that the workforce, specifically in social care, may be impacted significantly by Brexit and tighter immigration controls. And if we look at kind of average pay for social care, and the fact that actually many staff have come from EU nations, there's a real concern that in the proposed future immigration system, this will impact the recruitment of care staff. And so that may mean that many social care and health jobs don't meet the requirements for the minimum skills or salary threshold. So could it not be argued that this is not a priority for the government?
No, because, excuse me, when it comes to social care staff, I mean, first of all, there is a shortage in social care staff, both in residential care homes and domiciliary care. and I think it's very, over the last couple of years, we're seeing shortages in many parts of the labour market. And it's important we continue that investment in social care domestically. I think we should always try to look domestically first to meet our workforce needs. The funding announcements, so during the pandemic, the extra £34 billion that went into health and social care this year, much of that goes to support workforce, and also the longer term planning. So I referred earlier to the levy, the new health and social care levy. From that, at least around, I think, 500 million of that is earmarked for workforce training, over £1 billion for local councils in terms of trying to make a fairer, what's called the fairer cost of care payments. And that will all help, I think, with workforce and workforce retention. When it comes to overseas recruitment, obviously you'll know the rules around that are set by the Home Office and in the so-called sort of points-based system. And I think it's important that it does meet our workforce needs, but I also think it's important that it's reviewed regularly. And so I know it is, and although this department wouldn't lead that review, to me it's reassuring that the Home Office does do that regularly. And if we need to make a change for health or social care, then I'm confident if that was necessary, that change could be made.
Thank you. Barbara.
Thank you, and thank you for joining us, Secretary of State. I want to ask a couple of questions. It's kind of going on from where you are, really, in terms of what you've just said about the adequacy of social care funding and the impact that might have on the NHS over winter and some related areas like workforce, which you've just touched on. I just want to read back to you some quotes about the funding announced for social care in the budget. The 4.8 billion announced for local government over 3 years is not ring-fenced for social care. Response of the Directors of Adult Social Services was, "It's deeply disappointing that the Chancellor failed to recognise the crisis in social care that is already upon us and will now only deepen this winter. We're facing a perfect storm with care staff quitting, family carers reaching breaking point, care agencies going out of business, people with support needs waiting longer and receiving less care and support." The King's Fund has said, "Funding allocated is not enough to keep pace with demand and meet current pressures, including being able to adequately reward the workforce," described the sector as at breaking point. The Health Foundation described adult social care as one of the biggest losers in the spending review. To tackle unmet need and meet future demand, it's estimated that adult social care in England would require additional funding of £7.6 billion next year, rising to £9 billion the following year. I want to ask you how you think the NHS can be expected to cope with the coming winter and tackle the backlog when social care is under such immense pressure and there was very little in the budget or the spending review to indicate that there's going to be any relief for that pressure.
Thank you. There's a short-term need and a long-term need. So in the short term, and especially because of the impact of the pandemic, and let me just also, I know I referred to this earlier, but I can't say enough. I think everyone working in social care has done an incredible job. I mean, they always do, but especially over the last couple of years, it really absolutely, you cannot imagine a more challenging environment for them. And it's important we continue to provide all the support that we do. In terms of the short term, I mentioned earlier to our colleague that in this financial year, so before we even get to the spending review, in this financial year, there's been billions more put into health and social care. So in social care in particular, on the issues that you've asked about, there's in October I announced 162.5 million for a workforce recruitment and retention fund for social care, specifically for social care to boost staffing and support.
I'll come on to workforce,
workers.
but I read your Secretary of State the comments of the Directors of Adult Social Services, ADAS, their association, said it was deeply disappointing and that there won't be sufficient funding.
Are you referring to the spending
crisis.
review or more?
Well, all the measures you've announced. There has been, there is obviously additional grant funding going to councils. So that's not ring-fenced for social care. Yeah. That has to be spread across a whole wide range of areas. And, councils are cash-strapped to start with, so any additional funding that goes in, particularly if it's not focused on social care. I mean, we can come on
the funding going in this year, there is a record amount of funding extra going to social care to deal with a lot of the challenges around the pandemic, but it's support, of course, to bring about better social care. So from the NHS settlement, I announced, I think it was 5.4 billion extra for the NHS a couple of months ago for the second half of this financial year, and that included some £500 million roughly for social care discharge fund, because as you may be aware, there are some people in hospital that are ready to be clinically discharged, but they may need to go to a care home or may need domiciliary care at home, and that is extra support for the sector. But in terms of longer term support, I think you mentioned a moment ago that when you said the 5.4 billion wasn't ring fenced, I think you're referring to the 5.4 billion that's in the social care levy, the total 5.4 billion from the 30.
The grant to local government isn't ring fenced for social care. It's not.
Which grant are you referring to?
The extra funding that's going to councils over the next 3 years isn't ring fenced for social care.
Well, there's different sources of funding. Because as you know, social care, although my department has overall responsibility for overseeing the sector, the other department is the Department for Levelling Up, that's very much involved in that and working with local councils. So I think I'm right in saying if you look at the settlement that was announced last week, there's I think it's around £1.6 billion extra a year via local councils into social care, and that is specifically for social care.
Oh, I see. You're talking about the funding they raise themselves, the funding they raise through.
No, I think it's funding from there's the funding that goes to local authority has two sources. One is central funding from central government, and the other would be through the levy, the adult social care levy.
But the points I raised were to direct you to the fact that the reaction that there was to the budget and the spending review, to all the announcements in effect. There was a sense that the social care sector was waiting for funding that would relieve the crisis. And I read you those comments that I read you because the reaction was that the Chancellor hadn't listened and that there isn't enough funding and the crisis will not abate. So do you recognise that there's a crisis in social care and that the reaction was pretty damning, and that the view is that there isn't enough funding.
Of course, I recognise that it's an incredibly challenging time for social care. I think that was the case before the pandemic. There were huge pressures. The pandemic obviously has made it even more challenging. The government's response to that, part of the response, has been unprecedented levels of spending and support, financial support for social care, whether that's directly to the sector, to the care homes, or indirectly through the local authorities, or through the NHS, such as the discharge fund, and also the funding. For example, we provided I think some 388 million in the second half of this year for infection control measures that are needed in care homes. So there's different levels of support. You asked me, do I sort of recognise or hear the response of the sector? Of course I do. We talk to the sector at all times, and their representatives. I hear, of
in
course,
that sense,
what they're saying.
Do you think that you and the Chancellor have got it right then? Because, I mean, I can read you more quotes. Care England, which represents care providers, said there will be serious and far-reaching consequences from this lack of recognition of extra funding. The Care and Support Alliance, which is all the charities that support carers, and the care sector, says, if the Prime Minister's ambition to fix social care is ever to be realised, Rishi Sunak has to play his part by providing enough funding. He hasn't done so, and therefore the future of social care remains as uncertain as ever.
I don't recognise that. Of course, there are huge pressures, and of course there will be stakeholders that feel that, in their opinion, those pressures have not been met. I think in all the time that
it's all of them, though, isn't it? It's all the stakeholders. It's not some stakeholders think that it's in crisis. It's all of them.
Well, I was just going to say, in all the time that I've had the privilege to work with the social care sector and providers, including in my time as local government secretary, including as my time as chancellor, I don't think, and this is all pre-pandemic, I don't think I've ever known a time when stakeholders in the social care sector have been 100% satisfied with the support that they're receiving, and they're entitled to their views. What I'm most interested in are the facts on the ground, especially from organisations like CQC, for example, which will look at.
Can we come on to that? Can we come on to the social care workforce, which Anna, my colleague, raised with you, and which you touched on briefly. Recently, the Care Quality Commission, you'll know, published its State of Care report and described the social care workforce as exhausted, depleted, and drained in terms of both resilience and capacity. Now, that clearly has an impact on the quality of care they can deliver, and that knock-on impact to the NHS. You've mentioned wanting to discharge patients from hospital. When the Care Minister was interviewed on this, her response was the goal was to get millions more hours into the care system. Do you think it's possible for an exhausted and depleted workforce to suddenly produce millions of hours of extra care? Because that's what your Care Minister put out there, was the department's goal. What you're going to do is get more millions of hours out of, and a view that there was spare capacity in the social care workforce, which I have to say nobody outside of here thinks is the case.
Well, I think the sector is very stretched, and there are actually significant shortages in the workforce, especially in domiciliary care, comparatively to residential homes. And that is something that absolutely concerns me, concerns the Care Minister. It is, as well as the short-term extra funding that we provided, as I was alluding to earlier with Mr. Chairman, when he raised long-term issues around workforce, and it's as important that includes the needs of the social care sector. So I referred earlier to the work that the HEE has begun, that I've asked them to do, working with, taking a big tent approach, working with the care sector included, and I want that to include the needs of the care sector, because there is an issue, there is a long-term challenge, and I do accept that. I've never shied away from that. But also the way, the importance of I'd like to see more work, even more than we see today, between the care sector and the healthcare sector. There's some natural linkages. I think that working together they can produce better outcomes for people, and I want as we look at long-term need for the workforce review to take account of that as well.
I don't think anybody could see where the support is coming from, where the funding is coming from. You mentioned £500 million, which is meant to cover training and the fairer cost of care payments by councils. And that's what you've included. There's nothing there to increase the pay of care staff. There are 100,000 vacancies in the social care sector and a turnover rate of more than 30% a year. You can now earn more flipping burgers at a burger place than you can caring for somebody, and that's a real, damning indictment of our society. I think that we don't value that job.
Well, you'll know that almost everyone that works in social care, the vast majority are employed by the private sector. Unlike, for example, when we were talking earlier about
the funding comes from your department. The funding comes from your department through local government.
A huge portion of the funding, the majority of the funding, comes from direct or indirect government sources. But there's also still a significant amount that comes directly through your personal payments. But the point I make there is just that the government doesn't set the salaries in the sector. The salaries are set by the
you do indirectly providers. Because
we do indirectly.
You provide the funding.
And what we have done just last week was accept the recommendations of the Low Pay Commission on the national living wage, which will be an increase, I think, of 6.6% starting in April next year, which will be of significant benefit, probably disproportionate benefit to those working in the social care sector. So that is one way the income that someone gets can be influenced. And of course that will have to be met. When the government is setting the national living wage, in this case, obviously rightly accepting the recommendations of the LPC, that the Treasury certainly would have taken into account the extra funding that might be required for the sector to meet that commitment.
It's certainly of interest to the care sector because 3/4 of care staff only just get the minimum wage or less than the minimum wage, and very large numbers of them are on 0 hours contracts. But those are the conditions that we're talking about, and that's why turnover and vacancy rates are so high. But let's leave that there because there's another important aspect of this. I want to raise the impact on carers of discharging patients early from hospital under the new discharge to assess process. During the pandemic, 3 million more carers stepped up to care, and the time people spent caring increased, but less money was actually spent on supporting them in 2020 than had been spent in 2019. So they get very little respite and they get even less support. Now, the impact assessment for the new discharge to assess process, in terms of the changes that are going through with the bill at the moment, says this. There's an expectation that unpaid carers might need to allocate more time to care for patients who were discharged from hospital earlier. For some, this could require a reduction in work hours and associated financial costs. I can tell you, Secretary of State, that people who support unpaid carers were outraged by the assumption by the government that they would just drop everything, including their paid work, and just be able to take on a new caring burden. This has actually been a very, very damaging move by the government to just make that assumption and include that in a new process.
I think the discharging and trying to find better ways to do that. So here, just be specific, I think we're talking about people that are in hospital that no longer need to be there for clinical needs, and so, but they do need care. They need social care if they are discharged, and it's about making sure that that care for them, from wherever it comes from, is there, and the government provides whatever support that it can, either directly or indirectly.
But the assessment now comes later. Up to now, that assessment has actually occurred before discharge. Discharge to assess means the assessment comes later, which means the day a person's discharged from hospital earlier in cases than they would have been, somebody has to take responsibility for them. You can't get a care package up in 24 hours. And the government's assumption, in what I've just read to you, is that it's going to be a family carer that could require a reduction in their work hours and associated financial costs. You're expecting millions of unpaid carers to take the hit of earlier discharge from hospital. That's the impact.
I think each situation is different. There may be some families that are able to care, and of course there may be others that can't provide that kind of support. And
the government's making the assumption.
No, if they cannot, that support should be there. I would mention here that I do want to make sure that we are look at this now with the impact of the pandemic as well, and we take a fresh look at the integration between health and social care, because discharge is really at the heart of that, and how can we do it better, collectively between the health and social care system. There are some good examples, some better examples around the country.
Could I stop you there on how should, because really I think there's a very strong thought that this should be looked at, that this was a mistake to put down, that this assumption is that family carers will just be able to drop everything, drop their work, despite the financial implications of that, and just take on a caring burden without any assessment or involvement or asking them if they're able to do that. And that's implicit in this procedure.
Well, look, of course, I want to make sure that we get it right. As I understand it, before you became the Secretary of State in this department, I understand there were some changes out of necessity because of the pandemic impact that were made around discharge, and I think that is understandable, as the priority became to make sure that the health system was doing everything it can to take care of the over 500,000 people that entered hospitals sadly with COVID-19. And so some changes, I think, were made related to the pandemic. I think what you're pointing at is beyond
the knock on from that. This new process actually says that when patients are discharged early from hospital, and everybody understands with the backlog the need to try and clear hospital beds.
Barbara, I think we better make this the last one.
Yes, okay. The expectation actually falls onto carers. The thing that's wrong in this is that carers have stepped up during the pandemic, and that's
I suggest, Secretary of State, could I suggest that you write to us, reflecting on Barbara Keeley's comments, with any thoughts?
I was just going to suggest that.
Thank you very much indeed.
Just one final point.
One final one.
There's just a point about dementia funding, which is important to organisations out there. Diagnosis rates for dementia have fallen, and new analysis estimates that around 30,000 people are now waiting for a dementia diagnosis. It will cost an estimated $292 million to provide people with a diagnosis and clear the backlog. That's far more than the investment that's been announced by the department earlier this year. Given the impact of the pandemic on people with dementia, what plans does the department have to tackle the dementia diagnosis backlog and ensure people receive the support they deserve?
Well, we have, during the pandemic, of course, there's been a significant impact, whether it's on dementia or mental health more broadly. We have set out the mental health recovery plan, which is £500 million of extra funding during the pandemic. We also have the support that's going to mental health and dementia support more even before the pandemic. We remain committed to that, an extra £2.3 billion, I think, of spending in general by the end of this Parliament. And we are speaking to many people that are close to this issue to learn about what more we can do.
Thank you. Barbara, I'm sorry, but we're going to have to move on now. Dr. Luke Evans.
Just welcome. Primary care. Can you set from the outset briefly what your perspective is of the landscape of GP services from the doctor's perspective and from the public's perspective?
First, if I may, Mr. Evans, what I would say is that I'm really proud of our GPs up and down the country, and I think that there was a lot of demand pre-pandemic, but of course, because of the pandemic, whatever demand they had before, you just multiplied considerably for all of them. And I think that what we've seen throughout the country, especially over the last 18 months, that GPs are really stepping up and doing what was needed of them and answering the call from the British public. And as the Secretary of State for Health, and I think I speak for all my ministers and certainly all of them in the department, I think as a nation we couldn't be more proud of our GPs and what they've done. If you think of the vaccination programme, for example, as they are doing now, right from the early days of the vaccination programme to the booster programme, right now how vital that is. It's GPs that are getting out there to some of the most vulnerable in the care homes, in those that are homebound, and making sure they get their vaccinations, including of course the flu vaccine now as well. It's hugely important. So nothing but praise for our fantastic GPs. In terms of looking ahead now and the challenges, we saw during the pandemic, we saw people stay away from healthcare in the normal way, including primary care. We were told to stay at home, so of course people weren't able to go to their GPs if physically, in let's say if that's how they normally had done it. And there was a requirement for there would only be a remote consultation because of the rules of the pandemic, and people understood that, and the GPs again rose to that challenge. As we are now moving more to normal, we're not quite there. The pandemic is, of course, it's still there. It's very important that we keep our defences up against it, and more people are coming back to see their GPs because perhaps they'd held back before. That demand is increasing, and GPs are getting record numbers of appointments. And it's important that those patients are, that they can be seen as quickly as possible, and that where those patients have a desire to be seen face to face, this has been an issue of debate recently. I think that choice should be respected as well.
There's a rub there, isn't there? And what's the correct percentage, do you think, between face to face and remote contact?
I don't think there's a right or wrong percentage. I think it's more about, so I wouldn't, in my mind, there's no target, as in, if we want to put some numbers on just historic numbers, I think approximately pre-pandemic, around 80% of appointments were face-to-face appointments in primary care. And around, now it's around 60%. I think last month it was around 60%. And so that's where we are today versus pre-pandemic. But for me, it's never been about it should be 80% or 70% or something. It's not about a number. It's about doing the right thing, and ultimately, I guess it's about choice for the patient. Where you have a patient that wants to be seen face to face, perhaps the initial consultation might have been a remote, but they feel that they should be face to face. I think it's really important to try and meet that.
So I asked the same question to the CEO of the NHS, and she answered in exactly the same way. I guess the counter argument and where the rub comes from, where I sit, is what's clinically appropriate and allows the NHS to do more versus the patient choice, because it might be completely clinically appropriate for the doctor to say, send in a photo if you've got a digital camera of your skin lesion to the doctor to make a decision for the doctor to decide if they need to see you. The patient may say, I want to be seen face to face for that to be assessed. That is the rub that is happening on the coalface. Where do you stand on how do we resolve that?
Well, ultimately, is to recognise that there is huge demand on primary care services, and where we stand is on the side of the patient and the GPs in helping the GPs what they love doing, which is seeing their patients, and that was the purpose of the recent sort of winter access package, I think we called it, is working with the GPs, listening to what they had to say, is to come forward with whether it's funding or other interventions that will help them do more of what they love doing, which is seeing their patients. That was the purpose of the package.
You brought up the access, and that leads me on to the next part, which is sort of productivity and the access. Much was made about league tables. Do you plan on going ahead with league tables for GPs?
We never plan having league tables. We never have. That's never come from the department. It's never come from the NHS. I think what that might be a reference to by some is that the GPs in their last contract, which I think was negotiated in 2019, that it included transparency, the need for more transparency that GPs rightly accepted, and being able to publish data at a practice level rather than at the sort of regional CCG level. And that is something that's we intend to go ahead with, which was agreed back in 2019. I think understandably a lot of that data collection was paused during the height of the pandemic, quite rightly so. But I don't know where this idea of league tables comes from. I think that
Will that data include the proportion of face-to-face appointments by practice?
I think it will, yeah.
And broadly speaking, the figures roughly used, 9% of the NHS budget goes towards general practice, of which they see about 90% of the population. Do you think that figure's right, given the pressure they're under?
I don't know, to be honest, at this point. I don't know. I think certainly what we need is, especially now in light of the lessons we've learned through this pandemic, is a a transformative approach about how we deal with future health challenges, demand on healthcare, the waiting list, the electives backlog, mental health we just talked about, and I think that does mean a fresh look at how we see sort of how does primary care work with secondary care, work with community hospitals, work with people in the community, with midwives, and to take a fresh look at all that. And really? And I've started that process. So the leadership review. And as part of that is to look throughout the NHS and the care system, but especially focus on NHS, not just hospital leadership, but primary care leadership, community hospital leadership, and to look at where in some parts of the country there are different models of the relationship between primary and secondary care. For example, Wolverhampton, for example, parts of Wolverhampton have a specific model where I think that some of the GPs work directly for the NHS. So I think it's important to take a proper, fresh look at this in light of the level of demand, the changes in demand. But at the heart of it will again be, in primary care, will be our GPs. They do deserve a huge amount of support because they are facing unprecedented challenges, and it's my job to make sure that we are listening.
I'm really pleased you picked up on that, because I'm not going to go through the long term. My colleague's been through the long term plan, but in the short term, one of the things we saw in the pandemic was a revolution in the thinking that we could suddenly get rid of the red tape for whatever reason, and clinicians seem to have thinking space, and we've heard that from other witnesses in the last couple of sessions that we had. Is there a way you could foresee protecting thinking space for clinicians? Paid incentive through QOF, for example, where you could protect time for them to concentrate on the models of their local care. These revolutionary ways of enhancing the improvement in the NHS at the coalface seem a very sensible way, on the light of what you've put in the winter plan, access plan, about moving red tape of who's doing sick notes and things like that. Is there an emphasis in a plan to put that kind of practice in place? Because that will make a huge difference in the immediate effect. And how can the department capitalise on that?
Yeah, I mean, what we've announced in the winter access announcement, we're putting all that into place now. Some will move more quickly than others. So there's £250 million in the winter access fund. There's more use of the community, the pharmacy, the consultation service. There's some GPs, they came to us and said, our sort of telephone systems in terms of cloud computing and how the patient experiences when they call the practice, how we can change that. We're investing in that, and also the access improvement program as well. We've done all this, listening to GPs. If there's more we can do, I'm ready to try and do that. It's a really important partnership, and we'll continue to work with them.
My final question is about GP and workforce actually in primary care. Their wellness, their well-being. A lot of them are facing abuse. A lot of them are also facing burnout. Is there a programme the government could consider about how to look into simple measures that would support the welfare of the frontline services in primary care? Be it time to think, places to speak to, the ability to use some of the funding for team building. All these kind of things could make a huge difference to the quality of the working life, which may encourage more members of staff to stay on and continue to contribute to the NHS.
The short answer is yes. I think there is more we could probably do to help with that. And I think it's important we look at that. And can I just say something, because you rightly mentioned it, that sadly we have seen abuse of GPs and actually other healthcare workers and nurses, for example, as well. And just sticking to GPs for a sec, I think there will never, ever be an excuse to have any kind of abusive behaviour. We've seen horrific abuse, actually, of GPs. I won't mention the practice, but we saw real serious injuries, and someone could have lost their life in terms of the attacks that we've seen. I will never, ever, this government will never tolerate any kind of abuse to any kind of healthcare worker ever, zero tolerance. And the package I referred to earlier, one of the things I insisted putting in there, just to make sure that we were there and showing that we want to help in every way we can, was I think £5 million of funding for any kind of security need for any practice, be it CCTV, panic buttons, anything, if a practice thought that they needed it. If that money wasn't enough, we will certainly look to add to that and support our fantastic GPs in every way we can. We want them to feel absolutely confident in the work that they do, the incredible work that they do, and we will always support them. And you've just mentioned some ideas around, and obviously, I know you speak with experience and family experience as well, and you mentioned ideas where it's around sort of thinking space, team working and things, and I think those kinds of things are just the way to go. I think there's probably more we can add to that, but I think it's really, really important that the welfare needs of our GPs and all their primary care staff that are working with them are met and prioritised.
Thank you. Just before I bring my colleague Laura, on GPs, I just want to follow up with some questions about GP numbers.
Yeah.
In 2019, the government announced a target to get 6,000 more GPs by 2024, so about 1,200 more a year.
Yeah.
There's a bit of debate as to what's happened in the last year. NHS Digital say it's up about 300, excluding locums and trainees. But other numbers say full-time equivalents down 400 over the last year. But whether it's up 300 or down 400, we're a long way off the additional 1,200 a year that we were hoping for when your predecessor announced that new 6,000 target. So what are you doing to get that target back on track?
Yeah, so first of all, in terms of the latest numbers I have, if it's helpful, is to June 2021, so June this year, there's 1,000, in terms of that 6,000 number, there's 1,000, just over 1,200 more doctors in general practice.
In full-time equivalent? Because obviously part-time, if you include people who are working part-time, that doesn't give you the whole picture, does it? So the full-time...
I want to say in full-time equivalent, but I'm going to be careful because my notes here say 1,200 doctors since to the year, to June 2021, that are extra into general practice, so towards that 6,000.
Perhaps I could guide you because I have looked at the numbers. I think when it's full-time equivalents, it's there's actually a decrease. But I suppose the general point is that the numbers have not been going up. I'm sure you would accept as fast as we would like them to be going up. And I just wondered whether you have any...
And by the way, if I may also add, we also have another target of 26,000 other clinicians in primary care, and that is the latest number I have, again just to share with you with the committee's 8,880 to June 2021.
Okay, so is your view that we are on track to meet that 6,000 additional full-time equivalent
No,
GPs
I don't think we are on track. No. What are we doing about it? I referred to earlier the record number of students in the medical schools, lifting the caps last year and this year. I think that is part of it. The colleagues in the committee earlier referred to the importance of international recruitment. That will be part of it as well. But no, we're not on track. I would like to see. I certainly am looking at what more we can do. We definitely do need I want to see that increase, but I'm not going to pretend that we're on track when clearly we're not.
The reason I asked that question is because that 6,000 target came after a target I actually introduced in 2015 to have 5,000 more GPs by 2020, which we did not succeed in delivering. And we did actually in that period have a big increase in new graduates from medical school going into general practice. But the reason we didn't hit that target was because there was at the same time a big increase in the number of GPs going part-time or retiring early. Now the BMA say from their recent survey that a quarter of GPs are planning to go part-time in the next 12 months. So I just wonder, how do we stop history repeating itself?
Well, I think that obviously if anyone, whether it's a GP or not, the people have a right to whether they move to part-time, or some cases they might retire earlier than otherwise. And I think part of the answer, it comes back to the point made by Mr. Evans earlier, is that Dr. Evans earlier, is that is the point that we've got to make sure that we are listening to what can help GPs with their general work environment. As I said, and I absolutely recognise the pressures have been immense. I mean, they're unimaginable pressures. I think pre-pandemic we wouldn't have thought about this kind of pressure on our primary care clinicians, including the GPs. And we've got to look at what other ways we can support. It's got to be about investment in recruitment as well. And also for those that do want to work extra hours, and if that's a question of some extra funding or some other changes, it's important we provide that as well. So the £250 million access fund that I announced earlier, and that's just for the next sort of 5 months till the end of this financial year. That was partly put together because a number of GPs and their representatives came to us and they said that there will be some GPs that can work some extra hours, but you have to be able to fund it properly, whether they're locums or it's other types of support. So it's not all about funding, by no means it's all about that, but it's about looking at the whole spectrum of things that we can do to help.
Thank you. And just finally, one of the consequences of the crisis in workforce for general practice is that some new GPs are qualifying, and rather than joining a surgery or a practice, they're going straight into locum work because it can be better paid and more flexible. What do you think the impact is on patients when, rather than seeing their own GP, they're seeing a locum who they may never have seen before and they may never see again?
I think that so there may be some people that are quite happy not to see the same the GP, but I do think as a general rule, even if someone thinks it's okay to have a different GP every time, I think it's always better where you can to have someone that knows you, knows your medical history. If it's not necessarily the same GP in the practice, but the practice knows your history. I think that is important. What we are also seeing, I think, related to this is that I think there's also, just in terms of newer GPs graduating, just less of an interest to become a partner in a GP practice as well. That doesn't mean they can join, a GP can join the practice as a sort of salaried employee of the practice rather than a locum. But there's also seems to be less interest in becoming a partner now. I don't remember the latest numbers. I was looking just the other day. There seems a significant fall in that interest. And I think, again, going back to Dr. Evans' point about there's been the way people access GPs, demand, there's been such a huge change in years, and I do think it's we're getting to the point we need to take a sort of fresh look at this as well. So if there are things that are getting in the way of perhaps becoming a partner or becoming a salaried sort of GP belonging to a particular practice, I think we need to work out what those are, listen to the GPs and make sure we're reacting.
Thank you. Laura Trott.
Thank you, Chair, and thank you, Secretary of State. The Royal College of Emergency Medicine set out its view that virtual GP appointments had led to increased demand on emergency departments. I think it's fair to say that when we had the Royal College of GPs head in here, he refuted that. Where do you stand on this?
Can I just ask you to explain that a bit more? You talk about virtual access to GPs in general?
Yes.
Yeah. I think that during the pandemic, it was understandable why virtual access, whether that's most of it was through phones rather than video, but either way, why virtual access became a necessity. There was really, for many people, sadly, no alternative because of all the necessary rules. And where we are with that now is that as we move back to normal, that there's those rules that kept people away are no longer there. Plus, there will be people that stayed away from their GPs, understandably, when they were asked to sort of broadly protect the NHS. And people are now rightly coming forward. In fact, I want them to come forward. I want people to know that the NHS, whether it's GPs or otherwise, is open for them. As they come forward, it is important, as a point discussed a moment ago with Dr. Evans, is that they have, ultimately there's a choice in terms of how they're seen.
And do you think that as we see a rise in face-to-face appointments, that will help reduce the excess of demand we're seeing on our emergency departments at the moment?
I think as we get more and more access to primary care, that will certainly help with demand in accident and emergency, more generally emergency care. I want to share with you a statistic. I think I'm trying to recall that I was told the other day. I'll refrain from sharing the statistic, but I can tell you there's a significant portion of people that are turning up for emergency care when they could have actually gone to their GP. And that is not the fault of those people at all. They have stayed away from the NHS when they were asked to. They now want to be seen, and it is right. And as I said, I couldn't emphasise enough. I want people to come forward for the care that they need. But part of the reason I think people are turning up at A&E, perhaps when they don't need it, is because they're not able to get through to their primary care services in the usual way. And also I think the 111 service has a big role to play here. It can certainly, the people operating that can do a fantastic job in trying to direct people to the right type of care for them. And I mentioned earlier that we'll be sending out more around our winter planning in terms of the pressures we'll see, but part of that is also increasing the capacity of the 111 service.
Yeah, and I think the point that the Royal College of Emergency Medicine were making was exactly that lack of availability of GP appointments has led to increased pressure on.
Yeah, I think that general point is correct.
Yeah. And what, in terms of pressure on emergency departments more broadly, you mentioned that you're going to be looking at 111 as part of helping to relieve that pressure. What are your other plans in terms of helping reduce wait times with emergency departments?
Well, we set out, or the NHS, more correctly, they set out just very recently a 10-point recovery action plan, for urgent and emergency care, and that's been published. But the sort of kind of measures that have been set out in that already are work with ambulance trusts. There's been extra funding that's gone in for this winter. For example, I think it's £55 million on recruitment numbers. There's help to recruit more 999 call handlers and clinicians to work in the control rooms. And there's more capacity for frontline staff. This is on top of some of the investment that had taken place both pre and during the pandemic, but I believe there was some £450 million of investment that went into A&E facilities to upgrade them, for funding that went to some 120 separate trusts that needed that kind of support. And then there's the 111 First initiative, as we've called it, 111 First, which is to try and get more people to see the 111 service as some kind of like a front door to emergency care, so that if it's possible, is to call that service first, and of course, if it is an emergency, they can then perhaps even direct you which emergency department you might get seen more quickly, or if it's something that can be dealt with by a non-emergency part of the NHS.
And what do you hope that package of measures, what effect do you think that will have on wait times? Do you have any view on the number of people you expect to be waiting beyond the 4 hours as we go into winter? Because obviously it's very high at the moment. What effect do you expect that package of measures to have on people's experience of A&E?
Look, these are all measures there to help: the extra funding, the extra support, the extra people, the call handlers. You're asking me, so the effect of these measures will it's clearly be helpful in that get numbers moving the right way. If you're asking me, what does it actually mean in terms of the number of people seen or what might happen to the wait, it's incredibly hard to say. I couldn't put a number onto it. All I know is that these are the right type of measures. We constantly keep them under review. Obviously the NHS every single day have a whole team that look at this. I myself personally look at the NHS and have a meeting twice a week at least on winter plans, and we're constantly looking at what else needs to be done based on what we're seeing. And what we are seeing at this point, again, just to put it into perspective, is that first of all, winter's tough anyway, right? In normal years, winter's tough. This year, it's going to be extra tough because we've still got a pandemic, and we need. I can't emphasize enough how important it is for people to take their vaccinations. So if you're eligible, especially the booster vaccinations, but there's still some 5 million people that haven't taken their first jab yet in England. So it's important. The vaccination program remains hugely important. The flu vaccination program is the biggest ever this country has ever had. That's going to be even more important, I think, this year than before, because there was virtually no flu last year. It's going to be around this year, and we need to be prepared for that. And then, of course, there's all the suppressed demand. There's let's say the missing referrals. We estimate that the NHS estimates there's possibly 7 to 8 million people that would have come forward to the NHS normally, but did not because of the pandemic. And so if you take all of that together, the pressures, including therefore on A&E, are immense. It's a very unusual time, and we just want to be making sure that we are doing everything we can to help the NHS cope with those pressures.
Final question. You helpfully set out that there's going to be a plan for how we're going to address the elective waiting times. And that will correlate the kind of 30% increase that has been promised to the plan to achieve that.
Yeah.
The 30% increase, is that a permanent increase as you see it in the capacity of the NHS, or is it something that you expect to be ramped down? And if so, will the ramp down plan be included in the plan that you're going to set out at the end of November?
I'm not sure it's going to have as you've described it, a ramp down plan, but to your main point about is that a permanent increase? We're still finalising these plans, but I would like to think there's a permanence about it, because a lot of the investment we're making to get there will be things that will make the NHS broadly in terms of the amount of electives it can get through much more efficient. And if I can give an example, we've announced a huge amount of investment over, I think, certainly about, I think, 2.4 billion pounds in community diagnostic centres. So these will be, we've announced 44 already. It's going to be at least 100 with the extra funding that was allocated in the settlement last week. And these will be, in communities, as it's named, focusing on diagnostics, MRIs, CT scans and other diagnostics, these tests and scans, and these can help massively in dealing with the wait list. Most of the wait, if you take the sort of official waiting list, the 5.7 million number, the majority of people on that list are waiting for diagnostics. And so having these separate hubs that can do this, and the first 44 we announced, we plan to have up and running within 12 months, and they can make a huge difference. And once you get to the end of the sort of this SR period, these diagnostics centres will remain. The major investment would have been made. Of course, there'll be a continuous workforce requirement, but that will be covered in the long-term plans.
Thank you. Dean Russell.
Thank you, Chair, and thank you, Secretary of State, for your time this morning. I have a set of questions on mental health and then on technology, but before I do, can I just ask you a very specific question related to a visit I had to my local GP surgery on the case of inefficiencies, as it were. One of the things that was really noticeable to me was that they couldn't do PCR tests, so I sat in on a surgery where there was a young child there, and the GP needed to get them tested, but they had to then send them away to get the PCR test. And I just wondered if there's a reason why GPs, as I understand it, can't do PCR tests on site.
Do you mean just to take the swab?
Yeah, just take the swab and just send it off. That was my understanding, unless I misunderstood on the visit. I know it's a cause of concern.
To do a PCR test, the NHS system, that your NHS trusts the men that can do PCR tests. Yeah. You asked me specifically about in a GP practice. I'm not aware if a GP has a special allocation of tests. Certainly, GP surgeons will be able to access the tests. But I think if I understand your question correctly, is that would they have a sort of ready supply?
Or could they do the test? So if they've got a patient that they're seeing and they think perhaps they should be tested, could GPs be enabled?
But if they took the swab, they would still need to send it to a lab.
Yes,
for
absolutely.
assessment.
Yeah, I don't think they could take the swab itself, as I understood. Perhaps I could follow up with you separately.
Yeah, I'll find out, and I can certainly write to you about that and get your full answer.
Please, thank you very much. My first set of questions really is about mental health. I'm conscious that one of the big issues that's come out of the pandemic is both an increased awareness of mental well-being and mental health, which I think is a good thing, and reducing the stigma, but also an increased rise in people with concerns around their own and family members' mental health. Specifically around children and the use of CAMS. When do you think the funding and the initiatives that are happening at the moment that you mentioned earlier towards reducing the backlog of mental health will start to be seen? I'm very specifically conscious of parents who are concerned about their kids who are having to wait weeks or sometimes months to be able to see someone on that front.
Yeah, I mean, first, if I may, just to recognise that the mental health challenges have risen significantly because of the pandemic. And whilst I think everyone understands why we were all asked, to sort of stay away, stay at home and distance and all of that, not be able to see our friends and family, it did have an intended consequence of, through the social isolation and other ways, of increasing mental health problems, especially amongst young people, as you point out. And I say that to say it's important that everyone recognises that and understands then why that is a priority, that we deal with that. In most immediate term, that was the reason why we putting together I think we call it the mental health recovery plan, because of the pandemic, the immediate impact of the pandemic, and that was an additional £500 million just in this financial year. And as you would expect, that has been targeted to those people that have been affected the most because of the pandemic, and on top of the list, I think, have been young people with children or younger adults, and also frontline staff in the NHS and care system that have been affected. That plan includes £111 million of support for extra workforce as well, and that's an important part of it in trying to meet that need. More longer term, so beyond just this financial year, of course, we're going to have to see how we can better deal with these challenges. And we had already committed, I think, pre-pandemic, to an extra £2.3 billion a year by year 2024-25, and that hasn't changed. But in terms of our financial settlement that we just received as a department last week, we are looking within that what more can be done to support mental health.
Thank you. And just on that, just very briefly, I have to praise the work that has gone into mental health. I think over this past year, especially the support for the workforce in the NHS was incredibly welcome. I just wonder whether, again, just going back to timing, obviously April is a key date, but do you think over the course of next year we'll start to see that backlog for CAMHS, mental health for children, shortened and start to reduce? I mean, I just wanted to get a sense of timing of success on this.
I think that, unfortunately, I'd say that the backlog, whether obviously we're talking about mental health, but more broadly the backlog, I think will increase before it goes down the overall number. Why? Because as I mentioned a moment ago, there were some 7 to 8 million people, let's say 7.5 million people that stayed away, like the missing referrals. And of course, they're starting to come back. I don't know how many are going to come back, but if it's 50, 60%, whatever the number is, it's a huge number. And like I said, I couldn't emphasize that. I want people to come, and if they have any kind of health need, if it's a mental health need or any other, I want them to come to the NHS and know that it's there for them. There's the normal demand you'd have in any case on top of the sort of returning demand, and you take all that together. I think it means that waiting lists in general will rise before they get better. Now within that, obviously more people than ever before will be seen. I think we've said that with the elective recovery funding that we've already allocated, both from the SR and what we allocated this year, it means something like 9 million more scans and procedures and tests and things. So a lot more people will be seen because of this. But I think we have to be realistic that it's an unprecedented level of demand. We've never seen anything like it, and this is true throughout the world in any developed country that has a universal healthcare system. It's through every part of the UK. What I'm saying is true in Scotland and Wales and Northern Ireland as well. But there will be certain priorities within that. And if it's helpful, Mr. Russell, I can just set out because mental health has remained a priority during the NHS, I can just share with you some of the latest numbers I had here, which I think might give you some confidence that it remains a priority. If I look at the waiting time standard this is for psychological therapies for common mental health care conditions, For the latest figures, this is for the year to July 2021, they show that 98.8% of those people completing treatment waited less than 18 weeks for their treatment against a target of 95%. So it was 98.8% versus a 95% target. And also 92.3% of people completing treatment waited less than 6 weeks against a target of 75%. So I hope that reassures you it's an absolute priority.
And just very finally on the mental health topic, do you think finally under your leadership as Secretary of State, we will get a parity between mental and physical health within the NHS and social care?
I absolutely believe in that, and I'm glad that that's the policy, clear policy of the government, and I will do everything within my power to make sure that happens.
Fantastic, thank you. If I may now just to ask a few questions on technology.
Yeah.
I chair the All-Party Parliamentary Group on Digital Health, and we've been looking at lots of different areas such as data and so on. I just have a few questions about where the priority is for technology and digital, probably more fairly within the NHS and social care. Obviously, there's a lot of money coming into the system with the levy and the spending review and the announcements recently. But is technology being seen on the same sort of level as capital investment on bricks and mortar, given the fact that things like virtual wards
and there was an increase in this SR of £4.2 billion, I think, in real terms, since so in cash terms, and that's on top of the £32.2 billion we'd already planned, and I see much of that, taking the whole sort of allocation of capital. Your technology will be an absolute priority of this. It has to be. It has to be. There is no way, I think, the NHS can meet the demands upon it without embracing the very latest technology. And I've seen it at work. There are NHS trusts that have really gone out there, properly embraced technology. Like, for example, I recall a visit to Milton Keynes Hospital, where they're using, I think it's probably, I was told it's the first hospital in Europe to use robots for general surgery. And they're not only can they see more patients more quickly, but it's a better outcome for the patient because they can be incredibly accurate in a way a human hand cannot. And so, what should drive this is the outcomes for patients. But even the digital patient records, cloud-based technology, the use of AI, for example, for looking at images and assessing the health challenges from those images. We're investing. I pick AI because I know that we are investing hundreds of millions in that. As well, I think it's not only it's going to be an important part, but I think it's absolutely essential. I think without embracing the very latest technology, the NHS just will not be able to keep up with the very best treatments for patients.
And thank you, and it's very optimistic actually, and it's an area I'm very passionate about. And my own local hospital, Watford General, they've done fantastic work around virtual wards. Yeah. And I just wonder, is there a plan to make sure that learning of where there are successes on the digital front are shared across the NHS?
Yeah, the NHS already is running, I think they call it the Accelerator Programme for digital. And that is exactly the pop-up clinics, the virtual wards, the 3D eye scanners, the at-home antibiotic kits, AI in GP surgeries, and lots of things that are all to do with innovation and technology taken together. And the whole purpose of this accelerator, well, as it sounds, is to take the very best practice and make sure that all trusts are looking at it. And if I can, I just want to link this back to something else that are initiated, which is the leadership review. The reason I asked Sir Gordon Messenger to do that review is because I've seen already, in a few months I've been in this department, I've seen some really fantastic examples of NHS leadership, which is whether it's on the technology front, it's on staff welfare, and most important on patient outcomes. But I've also seen there are trusts that just could do a lot better. And leadership, no one can say leadership is the only answer, but it is an important ingredient. And without good leadership, you're never going to get the best standards. And I want to see how we can take, in the NHS, we have some of the best leaders our country has, really outstanding people. And how can we replicate that throughout the NHS so that it can be in every part of the country, because ultimately it's going to lead to better outcomes.
Absolutely, and just a couple of more questions, if I may. Just with regards data, there was a lot of fear-mongering a few months ago about NHS and data and GPs accessing patient data. Just two comments on that. First of all, one was, do you see a time with regards to the use of data where actually people will be able to access their things like summary care record from the time throughout their lifetime? So a child born today could have almost a data wallet which carries through them throughout their lifetime, which connects GP data to surgeries, to the NHS, to social care. So they have, effectively, you have a single patient view that carries through them but helps them with health outcomes. Do you think that's where we're heading towards, which actually has data associated directly with the patient that can be accessed anywhere within the system to improve their outcomes?
I hope so, but it's not round the corner.
Yes.
It will take time to do that. There are NHS trusts that are still using fax machines. Right? There are NHS trusts. Most NHS trusts actually, when they are scheduling someone for an elective procedure, surgical procedure, they're using Excel spreadsheets and WhatsApp groups and traditional email, and that's seen as great technology by some. Just to use there's a project going on right now, to just give you an example, with at Chelsea and Westminster Hospital Trust, and led by NHS Digital, and it's a pilot project where they've only been doing it for a few months, and all they've really done is said to consultants, instead of using WhatsApp groups and Excel spreadsheet to try and you schedule your elective procedures, why don't we just use something called a real-time database? Now, these databases have existed for 20 years on, right? And just by making that change, the impact has been transformational already in this pilot project, just in a few months. For the consultants themselves, some of them just can't quite believe how it's made their life easier, given them more time to do what they want to do, which is their elective procedures, but also for the patient, having much more knowledge and confidence of their appointment. Sometimes, obviously, they can't make an appointment, they need to change their appointment, doing it electronically. In this case, the patient will get a text message that will tell them their appointment. They can then respond yes or no, and they can change their appointment, all done electronically. And that is something that's just happening now. And so the good news is, though, that can be something like that, once as a proven concept, it can be rolled out very easily, and when it comes to cost, it actually saves money, right? It more than pays for itself. So, and that depends a lot on a better data, and it is important, I think, whenever I think about data, that is always, though, I think, to reassure people that whenever your data will be used in the NHS, the privacy is always going to be paramount, and also appropriate access to that data. But I think most people accept that the more digital the NHS can become in terms of access to data in the appropriate way, the better outcomes there can be for patients.
Fantastic. You answered my second question already, so thank you very much. Back to you, Chair.
Thank you very much. Paul Bristow.
Thank you very much, Chair. Secretary of State, I really enjoyed the answer to your last question about the spreading of innovation across the system. Now, I've been involved in health policy for 20 years, perhaps, and I've seen numerous plans to try and spread innovation and new pathways, across the system, but they've only ever worked partially. You even talked about surgical robots. I remember the Da Vinci robots have been used for kidney cancer, prostate cancer, bladder cancer for a long time. Yeah. But it's only ever worked partially. This diffusion of innovation and new ways of doing things. You say you want to tackle the backlog, quite rightly, by doing just that, spreading innovation across the system. But if it only ever worked partially in the past, what's different now?
Well, I'd say a couple of things, if I may, Mr. Bristow. First thing is that it's essential. I think we've got to a point, and especially with the impact of the pandemic and all the huge demand we're seeing in the NHS, get through that elective backlog, that we've got to do things differently. And when you look at that transformation, digital technology innovation is a necessity, right? And maybe perhaps in the past it wasn't seen as absolutely essential. Maybe you could use Excel and WhatsApp groups and get away with it. It's inefficient, It's not how you'd organise things, but maybe you could just sort of get away with it. We can't do that anymore. We need to. It is absolutely essential we have this transformation. And you know, I mentioned earlier the community diagnostic hubs, but the very latest technology. We want to be using, as soon as it's ready, the AI technology in the diagnostics, for example, in those hubs and elsewhere. We want to, in the surgical hubs, I've talked about publicly about having the hospitals that focus, part of the hospital can focus on a particular type of surgery, which cataracts, for example. I went to see at Moorfields Hospital, how they're using, including the latest technology, to see patients in half the normal time, more patients, more quickly, much better outcome for patients by focusing on it and making the very best use of technology, including the patient interaction technology that's used for that. So I think that one thing that's changed is just an absolute necessity. Two or three other things I would mention that I think that will help make it happen is one I touched on earlier with Mr. Russell was the leadership. I think it's not just about knowing what the technology is and its availability, but having the leadership that's willing to deploy it and prioritize. I think that leaders today that don't embrace digital transformation won't survive. I'm not talking just about the NHS, I'm talking more broadly, generally. You can apply it to a company, you can apply it to any organisation. Technology is so vital that if you just can't embrace it, then you should make way for someone who understands the importance of technology. And that's one of the reasons to have this leadership review, is I want to make sure that every leader in the NHS understands it's their job to promote technology and to embrace it. It's not your chief technology officer's job only, or your chief information officer's job. It's your job. And if you don't understand that, then you really shouldn't be working in the NHS. And then also funding. That's different as well. I've talked about some of the numbers. I won't repeat them now, but we're getting record amounts of funding for technology. And lastly, the support, the sort of ecosystem. You know, I talked about the accelerator program, for example, the work that happens in the NHS-X and NHS-D to try and support, you know, to give the general support. So I think there's no need to ask every trust to duplicate effort. You know, if at the centre it can give good direction in terms of the standards of data, for example. So systems, if you have different systems, they can talk to each other. It can be transferable, and to learn from experiences of others. You know, having the centre coordinate that, I think, is going to be, you know, making a big difference.
Thank you. I completely agree with you about leadership and some of the other points you made. But do you envisage any specific mechanisms or levers within the system that will encourage adoption of new technologies and new pathways to really counter what I think has been a cultural aversion, actually, to innovation? It's a not invented here syndrome. Yeah. So are you thinking about any sort of tariff mechanisms, best practice tariffs, any levers in the system that are going to encourage and create the incentives for trusts to do just as you say?
Yes. But I couldn't exactly tell you what those are now. You have to invite me back.
Okay, good.
You should, as a committee, perhaps consider. Perhaps the committee could help really with this and consider a real review on technology and innovation in health and social care. Now, it's not for me to say what the committee should or should not do, but I just throw it out there and see how it lands with the members of the committee. And also, if I can also just point to, you may know this, Mr. Bristow, but this is an important part of it, is there was a review commissioned, a very important review, independent review commissioned by my predecessor, Laura Greery, I think was I think that's the right name. She was asked, and I just talked to her recently, and she was asked to do a very wide-ranging review of technology within the NHS, the structures that could incentivise it, and the support that exists. And that review, it's almost complete. And I've sort of you've discussed the general direction of that, and I think it's going to be a very important part of helping to set the right direction.
Okay, well, I would encourage you to, if I may be so bold, to listen to my Westminster Hall debate this afternoon on NHS efficiency, and I may be giving you my own views on what those levers, you know, might be. But that's for others to determine whether they're wise.
Well, I may not be able to attend. I may not be able to attend, but I will certainly
it's for others
read
to determine
what you've had to say.
Well, thank you. It's for others to determine whether they're actually wise or not, but they're certainly my views. I wanted to move on to the independent sector. We've talked a lot about capacity, and when we've talked about capacity, we've talked about individuals and staffing and all that sort of thing. But it's also about the capacity of cath labs and theatres and being able to do the things we need to do. Could more be done to maximise the contribution of the independent sector to tackle the backlog? And if so, what do you think that is?
Yes, more can be done. And we will set out what that is in the delivery plan I referred to earlier.
Do you envisage the risk of an ideological or a cultural reluctance to use the independent sector that's been commissioned or gathered by this new money?
Not really. It's not something that bothers me, because the important thing is that, especially given the huge demand that we're seeing in the backlog we've seen for reasons that people understand, that we deploy everything that can help more people being seen more quickly. And certainly for what I've seen is that if someone can get their knee operation done, paid for by the NHS, completely free at the point of use to them, as it should be and as it always will be through the NHS, but they can get that done in the independent sector, then that's exactly what should happen.
Good. Well, I hope that's absolutely right. Just a couple more questions. On capacity in terms of staffing, I think one of the things we should be looking at is a wider use of physician associates, surgical associates, anaesthesia associates. But all of these professions are not yet regulated. What can we do to speed that process up and get them regulated? Because we want clinicians to operate at the top of their practice and not be doing the things that I guess more other colleagues could be doing. And I think physician associates and others are a route to doing that. So what can we do to get them regulated more quickly?
Well, I think that during the pandemic, it's fair to say that in terms of approach to what certain clinicians could or could not do, there were some flexibilities that were given, and I think rightly so, that was thought about because of the pressure of the pandemic. And it doesn't mean that now, as we are in a better place, and clearly can't stress enough, there's still a pandemic, and get your vaccines, everyone. But that as we learn the lessons from the pandemic, there might be some things that, in terms of flexibilities for clinicians, that we want to continue. I think if we do that, it has to be done on the very best clinical advice, working, for example, with the Royal Colleges and others. And should only ever be done for clinical reasons, and everyone should feel comfortable with any change. But I think there are flexibilities, like you've suggested, that could be done. And I mentioned earlier, right at the start of this session, that the HEE is doing this sort of Framework 15, looking at the long-term needs in terms of workforce, and that is something I hope they will be taken into account as well.
And just finally, Secretary of State, you talked a little bit about transparency when it comes to GPs and shining a light on some of the measures. What can we do to do the same across our whole NHS, especially on commissioning decisions? I mean, I think a lot of the problems I talked about making sure that everyone's doing what GIRFT say they should be doing, or what NICE say they should be doing, would be improved if that light was shone on these commissioning decisions. Are there other ways we can make the NHS more transparent?
We should always be, I think, looking to how can we improve transparency in the NHS. It is, as we all know, it's an absolutely huge organisation. There's understandably a huge degree of complexity, but we should be trying to find ways of producing more of that information in a useful way. I would point to some of the work, for example, in the bill before Parliament now. As we put the ICSs on a statutory footing, there are more transparency requirements than I think there were before, and I think that's absolutely right now that they become, or will eventually, subject to the will of Parliament, become statutory bodies. And I think we should be looking to see within those the ICSs, then the structures that are below them, what more transparency could be offered. I did allude to earlier when we talked about with Dr. Evans about primary care, for example, that there is a need, just pick another area where we should be looking what different ways we've seen examples around the country, how primary care is done, and how important is the transparency, and how can we use that? So if I might just point to the Office for Health Improvement and Disparities, OHID, in the department which I've created. That is, as it sounds, all about recognising that we have disparities in health outcomes across the country. If we are going to truly tackle those, we need the information. We need to understand where these challenges and problems are. So not just at primary care, but at every level. So I think the more information we have, the more transparent we're about it, the better evidence that we have in targeting resources, especially when it comes to prevention.
And just to confirm on transparency, it is your intention to publish the proportion of face-to-face appointments for each of the 8,000 surgeries in general practice in England?
That's my understanding at a practice level, that it will include that. But given I didn't negotiate the 2019 contract, I don't know the exact details of it. So if you allow me, just allow me to write to you and confirm that and just double check that.
Thank you. Dean had a quick follow-up.
Thank you, Chair. It's just a brief question, really. Last year, I did a lot of volunteering with my local hospital, and I really saw the power of volunteers, and in particular for young people. And I've raised in Prime Minister's questions before about the idea of an NHS cadet sort of workforce, as it were. Workforce is probably the wrong word, but an opportunity to get young people engaged with the NHS and social care through a volunteering pathway. And I just wondered whether that's been delved into further. I know I've chatted to some of your other colleagues, including number 10, about this further, but it'd be great to hear if there's any.
We do have just on. First of all, I agree with you on that and the importance of that for exactly the reasons that you said. We do have NHS cadets.
Yes.
And I don't have the exact numbers with me, but it is in the thousands, and I think it's been a very successful programme, and I will be looking to work with our colleagues in the NHS and see how we can build on it.
Yeah, fantastic. I'd love to share some thoughts on that.
I'd love to hear about it.
Thank you.
Thank you. You've been very generous with your time. I've just got 3 brief last questions, and then I'm going to give the very last question to Dr. Luke Evans, and it's not just because you called him Mr. Evans. But let me just ask my final ones, if I may. I mean, 2 of them are about patient safety, which, as you know, is something very close to my heart. The last time the NHS had absolutely huge waiting lists was back in the 2000s, when the then Labour government set about tackling them. And they tackled them pretty successfully, but one of the unintended consequences was a targets culture that led to some terrible tragedies in places like Mid-Staffs. So I just wondered, how do we make sure that this time we don't end up with those unintended consequences when it comes to the safety and quality of care?
Well, thanks for asking that, because that is one of the most important things that there can ever be for a health system, is to ultimately we are there to help people, and that means that patient safety must always be paramount. And I think you're right, Mr. Chairman, to point out that as you try to get through more and more procedures, get through this backlog with all this extra funding and new ways also to do things, that you don't unintentionally set up some risk for a patient that didn't exist otherwise. How we will deal with that, I mean, first of all, I would say that with everything that we do, especially the new procedures, because for that very reason, because they're new and they haven't been tried and tested, is to put patient safety at the heart of it, and to reassure me and other ministers that whether it's the officials or it's the NHS has absolutely thought about that very carefully and told us exactly what the risks might be or might not be, and how they're going to sort of mitigate any potential risks and manage that, and why patient safety has been clearly a key part of them coming with their new procedures. The second thing is independent scrutiny, I think is really important in this. I think for both, it's important to me, but I think for reassuring all patients and the work, for example, of the CQC and what it does in terms of patient safety, both in, I'm talking about hospitals and health settings, but also the care homes for that matter as well. I think that's going to be an important part of it. And I think as we set out more plans, our winter plans, our plans for the delivery plan for the electives, I think we will want to be clear that patient safety is going to drive everything we do.
Thank you. One of the things that obviously will make a big difference is the way the new ICSs are assessed, and we strongly welcome the fact that the CQC will be assessing the new ICSs, and you've said that will be part of the new health bill. We haven't yet heard that safety and quality will be one of the domains that they look at, although that was a commitment made by your predecessor. And we haven't yet had it confirmed that they will be Ofsted rated in the way that hospitals, care homes and GP surgeries are. Could you confirm that that is your intention, even if it's not on the face of the bill?
Well, safety and quality, of course, will be an important part of their rating, the work the CQC will do. In terms of Ofsted rating and Ofsted star rating, that is something that we are considering. I'm just trying to recall whether exactly the style of ratings that may or may not be used. But if you may, on the ratings issue, I'd rather write to you and make sure I get that right, because it's been under review now for the last couple of weeks, and we're yet to come to a final decision on it cross-government.
I think our concern is if you had hospitals and GP surgeries and care homes being assessed in one way, and then ICSs being assessed in a different way, it wouldn't be fair across the system. And I think the big benefit of the Ofsted system is the clarity for the public, so they know that the ICS in their area is outstanding, good, requires improvement or inadequate, and you call a spade, and if quality and safety are part of that assessment, then that's also looked at. So certainly from our select committee's recommendations, we are strong supporters of that transparency.
I understand that, and I'll write to you on that.
Thank you. And then just a final one from me, completely different, but you have touched on it. But I just really wondered what your sense was as to the future progress of the pandemic. You said that we may be coming towards the end. We know that there's still a high level of daily infections. There's a lot of pressure on the front line. But are you cautiously optimistic that the days of exponential growth in daily infections, where you have a doubling rate of the disease of 4 days or 7 days or 14 days, are now behind us?
I mean, first of all, to be clear, is that I don't think anyone's talking about an end at this stage to the pandemic. There's still a pandemic. We're in a lot better place today, as are many countries, than they were just a few months ago. Think about what it was like at the start of this year. And there's good reason to believe that this progress that we've made collectively can be maintained. And the heart of that progress has really been the vaccine program, which has been one of the most successful in the world. But we should also recognize, we now know, we didn't know before because we're learning all the time, that the immunity that one gets from a vaccine does wane, and that waning is more important generally the older that you are, and that's why we have our booster program. And it's really, really important. I couldn't stress it enough that if we want to consolidate and maintain at least the progress we've made, it is vital that anyone that is eligible for a booster vaccine comes forward. We've had, I think, now almost 7 million in England, and it's obviously more every day. We're opening up more channels to get that, but it's vital that people come forward for their booster vaccine to maintain this progress. On top of that, the testing regime, the surveillance that we have, the new treatments that are available that we've purchased and will use subject to MHRA approval. This is all part of our defences. But I think also it's fair to say it's the nature of this virus, as we've seen, that there can be no guarantees on progress. We all know what we've got to do. If we do our bit, I think that's what makes the difference. But there will be new variants. There's a variant of Delta at the moment, AY4.2, which there's no evidence to suggest that it's evades vaccines, which is obviously great news, but it could well be more transmissible than the original Delta variant, and that's something we are, with our international partners, are doing more work on. But it's just a reminder that there will be more variants, and so we all need to keep our guard, do our bit, get vaccinated, and I think if we all do that, there's reason for us all to be cautiously optimistic.
Thank you. And last but not least, Dr. Luke Evans.
Thank you, Chair. I'd like to take a step back and ask you a slightly personal question, if that's all right, Secretary of State. You've got a new CEO of the NHS. You've been in post for a few months. We've got the biggest crisis ever facing the NHS. What keeps you up at night, and what do you hope to achieve by the time you finish as Secretary of State?
Well, thank you. You saved the best till last at this committee. I think you said, what keeps you up at night? Well, I do like to put my worries to the side and try my best to get a good night's sleep. So I try not to worry about too much. But giving you a proper answer to that, I would say it's just what we talked about the pandemic, is that we are in a much better place, of course, for the reasons that I've said. But I do worry that if people generally sort of let down their guard and think, it's almost all over, or some cases all over, it's not. And we have to maintain this progress, we've got to keep all working at it. And the vaccines are the most important part, but it's not the only thing. And then related to that is the new variants. There will be new variants. We don't know what's going to come around the corner. If one day there was a vaccine escape variant, that would be of significant concern. It's not, of course, we think about that. Our international partners think about that. We work with our partners on that. There's a lot more defences we've got today, even if there was a vaccine escape variant. But I think it's important to keep that at the top of my mind as well, and make sure we're as best prepared as we can for what the pandemic has in store for us. And then, of course, there's all knock-on impacts of that. But if I had to sort of focus on one thing, it's making sure we continue to make progress against the pandemic. And your second part of the question was, what do I
hope to achieve as Secretary of State?
I've got three major priorities, and I hope to deliver on all of them. One is number one is the pandemic, COVID, and I want to keep the virus at bay. Number two is a recovery. We talked a bit about that today, about the elective backlog and the recovery from that. And then number three is reform, as we talked about today, whether it's digital leadership or otherwise. I think to maintain the progress of the NHS and our social care system and things, we need some significant reforms. I've already set some of those in motion. I don't have all the answers to all that, but there are some amazing people out there, and we need independent analysis as well that will help the government come up with those reforms. So those, if I can make progress in all three of those, COVID, recovery and reform, in the time that I've got in this job, I don't know how long I'm going to have in this job. Mr. Chairman here is a record holder in terms of that. But in the time that I've got, if I can make progress in all three, that would be something that I would appreciate.
Secretary of State, you've been very generous with your time. Thank you very much indeed.
Thank you.
That concludes this morning. Order.
Thank you.
Committee Room 8, sound.